So I'll present some work that I've been doing on severe pediatric malaria in East Africa. And I'm obviously presenting this work on behalf of a larger group of people who I will acknowledge at the end of my presentation. So as a background, malaria transmission intensity underpins almost all aspects of malaria epidemiology and disease burden estimation. And on different spatial and temporal scales, malaria transmission reflects changes in the dynamics of mosquito vector and the human host, as well as the interventions that are in place. So I will talk about this early description of severe disease incidence and transmission intensity that was described in the 1990s. And this was an era when there was chloroquine resistance, there was drug resistance. And so these two studies are examples of ecological analysis that were undertaken at various hospitals to define the age-specific rates of hospitalization. And this work from communities that had known level of parasite exposure and or some, for example, the Burkina Faso study used proxies of transmission intensity based on the altitude. So this first paper was data from East Africa, and this was in Kenya and Tanzania. And this was data from two sites that had very marked differences in transmission intensity. And the second paper was from the rural and urban extent of Burkina Faso. And from these two papers, which are, the results are shown by these two graphs. The insights that had very high transmission intensity, that is Ifakara in Tanzania, which are shown by the black bars, and the rural extent for the Burkina Faso is shown by the gray bars. It shows that the peak age of malaria transmission was high in these high transmission sites. But when you look at the lower transmission sites, which is shown by Kilifi, which is the gray bar, and the white bars are the urban extent of Burkina Faso, shows that the peak age of malaria was in older children compared to the higher transmission sites. And also another conclusion from these two studies was that the results, that the epidemiological context largely influences the clinical presentation of severe malaria in that point in time. So this next set of slides shows you studies. I presented this next set of studies in this figure. And the figure shows you the relationship between the rate of disease, which is on the y-axis, and on the x-axis, we have parasite prevalence or transmission intensity. And again, this is using data in the 1990s. And the first study that described the rate of disease among against community parasite prevalence in Africa was published in 1997 by Snow et al. And this is the paper that I put down here. And it used data from this first series of data, and these were in sites in Bakau and Sukuta in the Gambia, Kilifi North, Kilifi South, and Siaya in Kenya. And these sites are shown by the orange dots on this figure. So this is obviously not the best way of showing what that relationship looked like. But from these early studies, the conclusion was that as parasite prevalence increases, the rate of severe malaria also increases, and saturates at a parasite prevalence of about 40% before declining in higher transmission settings, or where parasite prevalence was much higher. And we should note that parasite prevalence of greater than 75% was relatively common in the 1990s, but is quite rare in the present day. And the other thing I think I should mention at this point is that presently in many parts of Africa, malaria infection and disease risk are in transition. And this is in part because of the scaling up of vector control measures, for example, the indoor residual spraying and the bed net use, and also the use of effective therapeutics. For example, we are currently using artemisinin-based combination therapy. And we have also different forms of chemoprevention, for example, seasonal malaria chemoprevention that is targeted at high-risk groups. And so how this changing risk alters the clinical epidemiology of severe and uncomplicated disease was a subject of concern over 60 years ago, and interest in this area has reemerged in the recent years. And so the three main hypotheses that were generated from this early data and which we have tried to address in the work I'll present today are: one, does the rate of severe disease saturate at high transmission or decline through early premonition? And what I mean by premonition is the maintenance of high levels of malaria-specific antibodies. And two, are there differences in severe disease phenotype across transmission range? And does the mean age of malaria hospitalization increase as transmission declines? So these are the three main hypotheses that we'll try and address using a much larger data set compared to what I've described before. And I think something I forgot to mention is these additional studies. So still in the 1990s, although these studies have not been published, they seem to conform to the initial hypothesis that was generated from this early study by Snow et al. And these sites are shown by the orange, by the green dots on the graph. And in that sense, we thought it really did conform with what Snow et al. Had initially hypothesized. So despite the significant increase in the coverages of control activities across Africa, like I had initially alluded to, and the changing landscape of infection prevalence, there has been no large-scale epidemiological description of the rate of severe disease among African children in the past 20 years. And so for that reason, we applied for the Wellcome Trust funding to revisit the empirical description of severe malaria 20 years on. And from here on, the focus of my talk will be on data that we've been able to assemble in an era of effective therapeutics. And in this case, what I mean is in the era of artemisinin-based combination therapies that are in use in Africa. And in a way, we are updating the information after the 1990s because nothing has been done in between what I've described in terms of the early data that I've shown and what I'm currently what I'll talk about and and the data that I'll show you that we were able to assemble. And so we have recently published this paper in the Science journal that describes the rate of severe malaria using data on patients with easy access to hospital and where it was possible to define the population at risk. So in the next few slides, I'll take you in further details the three parameters that were required for this study. And this was population in order to describe the rates, malaria admission with a parasitological confirmation, and transmission intensity as measured by community parasite prevalence. So in this study, we analyzed surveillance data from 13 hospitals in East Africa, as shown by this map. And these were in Uganda, Kenya, and Tanzania. And the blue dots just shows you the spatial locations of these hospitals that were included in this study. And so we aimed to define the rates of severe malaria. And therefore, in order to do this, we needed to know the population at risk. And so to do this, we matched the residential addresses recorded for each malaria admission to the smallest defined census unit, which then formed what we call the catchment area. And so these were catchment areas that were proximal to the hospital, but excluded the urban extent. So for example, if you look at here, Kakamega and Vihiga, there's a white space around the hospital, and this is the urban extent of these sites. And this was excluded from our definition of what would be the catchment area for that hospital. And so finally, we included 26 communities that are shown by these arrows for each of the hospitals. And the data covered 35 site time periods. And this is because some of the sites contributed data for more than one time point. And so to compute the population counts of these selected catchment areas, the population counts were derived from the national census projections. And we also used the age structures as provided by the demographic household survey data to try and compute what the age-specific population estimates were for the data that we had included, or for the catchment areas that we included for this work. However, for Kilifi, because we have a DSS site, demographic surveillance system ongoing, we actually used the household continuous population surveillance data, and this was used then to define what the person years of observations were. So I should also mention that these 13 hospitals were purposely selected, and this is because they had continuous pediatric ward surveillance established either for the purpose of monitoring acute febrile illnesses, and these are especially hospitals in Uganda, or disease burden epidemiology, and these were hospitals in Western Kenya, or in research settings, for example, Kilifi, where the aim was to improve the hospital case management. So in all the hospital sites, surveillance was conducted 24/7, and an electronic medical record form that recorded the features of severe malaria were maintained. And this data was obtained between 2006 to 2020. And so these, for example, are some of the forms that are used in some of these hospital sites to collect some of these symptoms for severe malaria or malaria signs and symptoms. So malaria admission was assembled for at least one complete year, where at least greater than 90% of the febrile patients had been examined. And these were among children aged 3 months to 9 years. And malaria was formally defined as a primary clinical diagnosis with a confirmed positive malaria slide taken at any time during the admission. And we did not include major underlying conditions, for example, sickle cell disease or HIV. So the other thing that we also tried to do was to assemble the 3 most common pediatric phenotypes of disease severity, and these were classified from the children that were admitted with malaria. And these included severe malaria anemia, respiratory distress, and cerebral malaria. And I'll talk more about these phenotypes in later slides. So for the malaria admission data, we finally included over 6,000 patients for this analysis. So the final parameter that we required was parasite prevalence. And so the malaria admission data that I have just described was then spaced and earmarked to an estimate of malaria transmission intensity. And this was using either community-based or school-based infection surveys. So for the community-based household parasite prevalence surveys, data was assembled in Kilifi and Siaya in Kenya, and in Tororo and Jinja in Uganda during the 2012 to 2013 surveillance period. In addition, surveys of malaria parasite prevalence among school-age children were established during or within the 4 months of the pediatric ward surveillance. And this was in Western Kenya in these sites, Busia, Bungoma, Homa Bay, Kakamega, and Vihiga. And in Uganda, we also assembled school-based surveys data in Apache, Mubede, Kabale, Tororo, and Jinja. And for Tororo and Jinja was during the 2017 to 2019 surveillance period. However, we were unable to extract an estimate for Muheza, Tanzania, and therefore we used published estimates for parasite prevalence that were extracted from literature. If you have any question, or if I've lost you, can raise a hand or just ask me a question, then I can try and explain or repeat what I've said. So this slide is on uncertainties in the outcome and exposure measures. And so our data set had 2 important sources of uncertainties that we aimed to control for. So the first source was in the classification of severe malaria. And this is because between site comparisons can be challenging owing to the differences in completeness of symptoms and also differences in clinical definition, which you will see in later slides. I'll demonstrate what I mean by that in later slides. And then in the second source of uncertainty would be on the measurement of infection prevalence. And this is because, for example, the community surveys and the school-based surveys I've just described were conducted in different age groups and using different sample sizes. And so in the next few slides, I'll describe how we controlled for these uncertainties. So this slide is on the completeness of symptoms reporting for severe malaria phenotypes. And across sites, as you can see from this heat map, symptoms were not systematically recorded. So on the x-axis, we have the symptoms, and on the y-axis, we have the sites. And the green hits indicate close to 100% reporting, and the red hits indicate close to 0% reporting of any specific symptom. And the numbers that you can see here are the actual reporting coverages for each site. So to a large extent, as you can see from the heat map, reporting coverage of majority of the symptoms was fairly complete. So for severe malaria anemia, so how we define severe malaria anemia was a hemoglobin level of 5 grams per deciliter. And as you can see from this first panel, the coverage there were gaps in the coverage or reporting coverage of HB levels, hemoglobin level. And so in this instance, what we call severe pallor and an indicator or whether blood transfusion was ordered were used as proxy measures for severe malaria anemia. And their coverages are shown by these 2 panels here. And respiratory distress was defined as deep breathing, and respiratory distress was widely reported, as you can see from this panel here, except for one for Sierra Hospital, which is shown by these 3 rows here. They're all from Sierra Hospital. And so deep breathing was not recorded or documented in Sierra, and therefore what we used was intercostal recession as a proxy measure for respiratory distress. Finally, that common phenotype was cerebral malaria, and cerebral malaria was defined as a blunt coma score of less than 3, and the reporting coverage of BCSC is shown on this panel. Additionally, the child's neurological status based on the AVPU scale was used, and in this case, unconsciousness level was deemed equivalent to a BCSC of less than 3, and the coverage of AVPU is shown here. So just like I said, different sites use different definitions for, so for example, for cerebral malaria, sites in Uganda use AVPU scale, and sites in Uganda and Western Kenya use AVPU scale, but Kilifi, for example, Muheza, and Bungoma used BCSC as a definition for cerebral malaria. And so to reconcile that, that's how we then defined cerebral malaria using a BCSC of less than 3 or unconsciousness in the AVPU scale. And since these 2 measures, the blunt coma score and the AVPU scales were widely reported, we, as you can see from this heat map, we did not model the diagnostic uncertainties in cerebral malaria. And as a sensitivity analysis, we tested the robustness of using unconsciousness level and unresponsiveness to pain, and to see whether that would make any difference in the modeling that we had done, and there were no differences. And so to determine the predictive performance of the alternative definitions of the other 2 severe malaria pathologies, that is SMA and RD, we developed a Bayesian procedure that leveraged data from sites that had that reported multiple indicators. So for example, if you look at this site in Sierra, they reported data on HB, pallor, and transfusion. So we leveraged that data to see how then we would be able to use these proxy measures as an alternative definition for severe malaria anemia where HB was missing. And so the aim here was then to determine the probability of correctly diagnosing a patient as having severe malaria phenotype while using these proxy measures. And so in the next few slides, I'll show you the results of this implementation. So I'll start with severe malaria anemia, and which I will call SMA going forward because it's a bit of a mouthful. So the graph on the left shows you the distribution of hemoglobin level relative to blood transfusion and severe pallor. The gray region here shows you patients that would have been classified as having SMA. So this set of box plots shows you patients or children that had blood transfusion ordered, And this is among that did not have a blood transfusion ordered, but this is among the ones that had a blood transfusion ordered. And the blue box plot shows you instances of severe pallor, and the green ones are instances that of children that did not have severe pallor. So when you look at this last box plot, visually, we can see that greater than 50% of the children that had both severe pallor and blood transfusion would have been classified as having SMA. And so the predictive performance of these two proxy measures was then formally assessed within a Bayesian framework. And we used a binomial distribution, and the results are shown by the graph on the right. So the graph on the right shows you the estimated rates of SMA on the y-axis, and on the x-axis, we have the sites. So the green circles with the vertical lines shows you the predicted median rate of SMA with their credible intervals using all three measures. The crosses here just shows you the rate of SMA based on patients with only hemoglobin level recorded. And the diamond is the interpretation, or the rates based on the interpretation of all the three measures. And as you can see from this, if SMA rate was defined using hemoglobin level only, this would have grossly underestimated the rates in sites with incomplete reporting. As you can see, the using the proxy measures, the rates, for example, for a patch was a bit much higher than what would have been estimated if you only used HB level only. So this next slide is on respiratory distress, which I'll call RD going forward. So the predictive performance of intercostal recession was only relevant in this case for Sierra Hospital, as this is the only site that did not report deep breathing. And so the graph on the left shows you the relative proportion of RD with an intercostal recession. So the green bars shows you instances without RD, and the blue ones are instances with RD. And accepting that intercostal recession is not perfect, we model the RD rates using intercostal recession, again, within the Bayesian framework and using the binomial distribution. And the graph on the right shows you the estimated rates of RD. And in this case, the most notable adjustments were made in the Sierra site, which are shown by these lines here and crosses. And as you can see, we can see that the uncertainties of using intercostal recession were taken into account, as you can see from these vertical lines. So the second source of uncertainty was in the measurement of infection prevalence. And like I mentioned earlier, parasite prevalence were undertaken among different age groups with different sample sizes. And so using this expression here, we evaluated parasite prevalence within the 2 to 10 age limit while estimating the probability of being positive. And what this gave us was an age standardized value of parasite prevalence for each survey, and for which the uncertainty in sample size was also taken into account. So this graph shows you the range of age standardized parasite prevalence, which is on the y-axis, and on the x-axis, again, we have the sites. And so this range from a negligible of less than 1% in Kilifi and Kabale, through to the high transmission sites of greater than 60% in Siaya, Tororo, and Apache. And the uncertainties in these measurements are shown by the vertical lines, which I should note that in most of the other studies, the uncertainties in parasite prevalence have not been modeled, but we tried to model these uncertainties in this in the work that I'll present, or in the results that I'll present later on. So the parasite prevalence reported here does cover the range of endemicity typical of East Africa today, which is very different from the one we talked about in the bit of background. But there are very few sites with a parasite prevalence of greater than 60%, and no site was above 70%, at least the ones we included in this study. So finally, once the two uncertainties were accounted for, we explored several potential functional relationships between the rates of severe malaria and parasite prevalence. And this was specified within the Poisson and negative binomial model. And we assessed 3 model forms, or we explored 3 model forms, and these were intercept only, log linear, and a 3-parameter log logistic model. And the Bayesian inference was then used to choose between these candidate models. And one thing I should also mention is that these regression models were implemented with the propagated uncertainties in the parasite prevalence and the syndrome reporting. So we also accounted, what I've just demonstrated on how we accounted for the uncertainties was also implemented in the regression model or accommodated in the regression model. So the next few slides, I'll present the results of these models. So there was a definable relationship between the rate of admission for all the 3 severe malaria phenotypes and the age standardized parasite prevalence. So on the y-axis, we have the rate of severe malaria, and this is among children aged 3 months to 9 years. And on the x-axis, we have the infection prevalence or the age standardized parasite prevalence in the 2 to 10 age limit. So the median fit of the Bayesian regression model is denoted by the thick black line with the 95 and 99% credible intervals shown by the dark and light blue envelope. And this is, for all the graphs that I'll present, this is how they all look like. And so that is what they mean. And from this graph, we see that at a low parasite prevalence, the rate of severe disease was low, and severe malaria admission rate was much higher, above an infection prevalence of 40% compared to previous work. And although in many sites, a parasite prevalence of greater than 70% is a rare event, we cannot rule out a plateauing or a decline in severe malaria rate beyond this infection prevalence, as we couldn't tell what might happen beyond that. And so what this model suggests is that for every 25% increase in parasite prevalence, the annual severe malaria admission rate approximately doubles, and the credible intervals were between 1.6 and 2.7. So this is on the severe malaria phenotypes. So by far the most common phenotype was severe malaria anemia, followed by respiratory distress, and cerebral malaria was very rare. So the effects of community parasite prevalence on SMA was multiphasic, as shown by this first graph. So when the community parasite prevalence was low, the admission rate was very low, but it increased sharply thereafter and was asymptotic at high transmission areas, as you can see here. And we also observed a positive correlation between the rate of respiratory distress and infection prevalence, as shown by this second panel, although the rate of RD did not dramatically increase as what we saw with SMA. However, we did not observe any correlation between cerebral malaria and infection prevalence, as shown by the panel C for all values of parasite prevalence. And so what this means is that the rate of CM does not change with endemicity, but might account for an increasing proportion of severe malaria cases under low transmission settings. So we also explored the relationship of admission rates with age and parasite prevalence, as shown by this graph. So on the y-axis, we have the standardized parasite prevalence, and on the x-axis, we have aging years. The red hits indicate high severe malaria admission rates, and the green, blue indicates low admission rate. And so what we found from this analysis is that below a critical community parasite prevalence of what we estimated as 16%, we found that the rate of severe malaria was uniformly distributed across age. And what this means is that in low transmission sites, there is little or no age dependency in severe malaria. But at sites beyond this critical point of 16%, the peak age of severe malaria rate decreases with increasing transmission. So for example, if we look at parasite prevalence of about 70%, the peak age was among infants. However, as parasite prevalence declined, there was a shift in the peak age of admission towards older children. So for example, if we look at parasite prevalence of 20%, the peak age is about 2.5 years. But you should also know that in these low transmission sites, the overall rate of admission was also incredibly low. So this is another way of visualizing the same data from the previous slide. So on the y-axis, we have the rate of severe malaria, and on the x-axis, we have age in years. And the colors just of the smooth line just shows you the cutoffs for transmission intensity, with red showing high transmission intensity and the blue showing very low transmission intensity. And the take-home message from this graph is that after the 5th birthday, we see that the admission rates declined phenomenally, regardless of the level of transmission. As you can see, all the lines converge after the 5th birthday down here. So I will begin the discussion by mentioning that this is the largest series to document, the largest series of data to document the relationship between the rate of severe malaria and community infection prevalence to date. And it's also the first time that the level of uncertainties in the outcome and exposure measures have been evaluated in an epidemiological study. Because the assumption is that our outcome is always certain, you're 100% accurate with the measurement of the outcome, but we've demonstrated that otherwise in this study. And one caveat I will mention is that this is an ecological analysis and not a longitudinal study. However, the detailed long-term data series are very rare, and only 2 sites exist on longitudinal studies, and these are in Menisa in Mozambique and in Kilifi, Kenya. And so therefore, this ecological analysis presents an opportunity to infer what transitions between different transmission regimes might present in terms of the rate of severe disease and the age distribution of malaria. So here we have provided a data-driven analysis of the impact of reducing transmission intensity on the severe malaria admission rate. There are interventions to reduce malaria transmission, as I had mentioned earlier. For example, master of drug administration, indoor residual spraying, and bed nets. And here we are suggesting that a 25% decrease in transmission will halve the rate of severe malaria admission. And we have also shown that as transmission declines, there's a shift in the peak age of severe malaria admissions towards older children. However, the overall admission rates are very low. So severe malaria anemia remains the primary severe disease phenotype, and cerebral malaria was a rare event. However, the constant rate of cerebral malaria across all transmission settings inevitably means that cerebral malaria will account for an increasing proportion of severe malaria cases under low transmission settings. So our data also shows that there's very little severe disease after the 6th birthday, and our results therefore support continued targeted infection prevention strategies towards young children. So there are two individual level protection strategies that have the potential to augment the current emphasis on vector control. And these are IPTI, which means intermittent preventive treatment for infants, and RTSS, or the R21 vaccines. And decisions on the implementation of these new malaria strategies must be tailored to the local health system and epidemiological context. And the data I present here, for example, shows the priority areas for the RTSS malaria vaccine rollout. So there is some further work that we hope to generate from this, from the data we assembled. As I have shown, we've assembled a huge amount of data from East Africa to better understand hospital incidents, severe malaria phenotypes, age and transmission intensity. And so in collaboration with Swiss TPH, we are exploring ways of using this empirical data to reparameterize and pressure test the existing component of their mechanistic model, which we call the open malaria model. And this is because this model is used by the WHO funders and policymakers to guide the implementation of these new malaria control strategies or malaria strategies. So I'd like to acknowledge plenty of people to acknowledge as listed in this slide. And this is in Kenya, Uganda, and Tanzania. And I also like to acknowledge Rob, Jose, and Sunetra for their help with the modeling work. And Bob was funded by the Wellcome Trust. Thanks. I'm happy to take questions.
Yeah, thanks a lot for that, Alice. If there are any questions, feel free to either type it into the chat box or just raise your hand or unmute yourself and ask. And probably to start, I could just ask what you think is the effect of better interventions on the shift in the plateau in intervention versus admission rates in your study. So comparing the 90s to your current data.
So that's a good question, Victor. So if you look at in the 1990s, there were no interventions in place, and there was there was chloroquine resistance at that point. So in a way, we could call the 1990s a steady state where there were no control. There was nothing that was changing the transmission intensity at that point. But with the current day scenario where we have vector control measures, we have effective therapeutics, we are seeing a more volatile situation. So for example, I'll give you an example, which I wasn't able to show here, is there was a site in a patch where they used to have IRS in place. And once IRS was removed, the rate of severe disease shot beyond what there was before the IRS were put in place. So this kind of data allows us to understand the impact of bringing in interventions and removing them, and what that might have, of the overall effect of that. And so the relationship, which is sort of like an exponential relationship that we find in our study, is just a situation which allows us to evaluate the dynamics that are occurring, and not the assumption of a steady state where there are no interventions put in place. So a patch, for example, did influence how that relationship between severe disease and transmission intensity looks like in the current day, for example. I don't know whether I've answered your question.
Yes, you have. Yeah, so also extrapolating, I guess your data doesn't capture the COVID period, but would you anticipate that there was an effect, or were there any disruptions in these interventions that may have affected admission rates, for example, in your sites?
Well, yeah, like you said, we don't have data beyond we actually did 2020, but yeah, beyond 2020, we don't have data for that. So I can't say for a fact what happened, but like I say, I think if interventions are withdrawn, we are seeing an effect in the change of the presentation of severe disease. So even older children are being seen to have severe disease simply because, so for example, if an intervention has been in place for the last 5 years, and so this child has been protected and has not been exposed, then what that means is that if the intervention is withdrawn and they are exposed, chances of them getting severe disease are quite high in that situation. So I think that the assumption would still hold if interventions are withdrawn, COVID-19 being there or not.
Okay, yeah. So there's a comment from David Kunjok in the chat box. So it's also a question I had about the rollout of the Mosquitotrix vaccine. So he says that the efficacy is better in children between 6 and 9 months. So the idea is to reduce severe malaria, and your work indicates that the most affected are below 6 months. So how would you address the gap? Or how would you suggest you roll out the vaccine if it works best beyond the age range in which you're experiencing the most severe cases?
Yes, I guess, so not even the vaccine bit, even the chemo prevention strategies, there are talks given the data to try and extend some of these interventions to older children. I can't say much about the vaccine, but I can talk about the IPTI, which we have tried to evaluate what the effect, or other studies have tried to evaluate whether the effect of administering that intervention to older children would have an effect on the overall burden. And these are discussions that are in place. And I think, yes, given the data that we're presenting, it's something that we would like to take forward and have talks with the policymakers and people in those lines. And that's, I guess, why we are also collaborating with CCTPH, because they work a lot more with the funders and the policymakers at our global scale in order then to, make better informed decisions on what age ranges should be targeted for some of these interventions. I can talk about the vaccines a lot more because it's not my area of expertise, to be honest, but I think these are useful suggestions or comments.
Okay, thanks for that, Alice. So there are a few raised hands, so we can probably go to those in order. So we can probably start with Caroline.
Thanks very much, Alice. Really nice presentation. Maybe my question isn't fair given your last comment about not being able to comment much on vaccines, but I'm interested in vaccines, and I don't know very much about malaria. So are you able to comment on what the mechanism of the vaccine is? I mean, will it reduce transmission, or is it just aimed at reducing disease severity?
So the greatest effect is on reducing disease severity and more on the transmission intensity. But I don't know, Rito, would you be able to make a better comment on that? Because, or let me see whether there's someone within the chat that I know would be able to address that better than I would. Rito?
Yeah, so I think, yeah, from the little I know, I feel, and the efficacy rate, I feel like it's more likely to reduce severity.
Yeah.
Yeah, so just the incidence of severe disease rather than malaria in itself.
Yeah, I guess the aim, I mean, getting a vaccine for malaria has been very challenging because of the polymorphism of the disease. I'm not choose the right word, but I guess, so the aim then was to reduce the number of children that were dying from it. And so that's why then the recommendation for the RTSS, for example, vaccine to be rolled out in Africa to reduce the burden of severe disease, which consequently leads to death. But the infection prevalence or the transmission intensity the vaccine has very little, if no effect on.
Thanks, Alice. We can move on to Sylvia.
Thanks, Alice. Great presentation. I had a few questions. What would you say are the main determinants? Can you get me?
Yes. No, go
ahead. Yeah.
So what would you say are the main, so what really determines transmission intensity? Are those human factors, vector factors, or environmental factors? Then my second question, so for the graphs where you indicated or you showed the different sites and the different, say, SMA rates, parasite intensity, are there patterns you see that determine why certain sites are on the extreme ends of those values, so to speak? Then my third question is, what determines whether malaria episode results in cerebral malaria? And lastly, what is your interpretation of why there's an age shift when parasite prevalence declines? Thank you.
Right. So many questions. So I guess the first question, I think it's an interplay between all those factors you've mentioned. So the vector, the mosquito vector, the human behavior, and the environment. So for example, if the environment is not conducive for the parasite the mosquito to propagate the parasite life cycle, then obviously transmission is not going to occur. And so the environmental factors do really determine the transmission intensity level. So for example, the Burkina Faso site that I talked about in the beginning, sites that have high altitude are said to be less conducive environment for mosquito vector to breed. The parasite itself, sorry. And so the transmission would not be high in those areas. And also the human behavior. So if you sleep under a bed net, chances of you getting bitten are much lower. And so the human behavior also has an effects on whether you will get the disease or not, if that makes sense. second question was on what makes some of the sites appear in the most extreme ends of the transmission intensity. I guess is, like you say, is the environment. So in Apache or in the Uganda site, for example, the transmission intensity is quite high. Or let's give an example. Let's come home. Look at Kilifi and Siaya. So Kilifi, the transmission intensity level would be regarded as low to moderate, but in Siaya would be regarded as high to moderate. And I guess the environmental conditions are what, and the parasite, the mosquito, the Anopheles mosquito vector, and then the environmental conditions would be the biggest drivers of why there are different transmission levels or intensities within different countries or within the same country in different sites. I don't know whether I'm answering the questions, but I'll go on and then you could tell me whether I have. About cerebral malaria, it's one of those questions that I also ask myself. I'm not very clear about what determines what phenotype or what disease you would eventually get once you have you've been bitten by a mosquito. And lastly, I forgot the last question.
The last question was about that age shift whenever.
All right.
Yeah.
So the assumption is that at low transmission settings, chances of you getting a bite are much lower. And so, so what that means is that if you're very young, you're being protected under a mosquito net, your transmission intensity level is very low. And so as you grow older, you get much more exposed. I mean, the behavior changes. And so your chances of getting a bite from a mosquito is quite higher. So consequently, what that means is that you're sort of like delaying. When the transmission intensity is low, you're delaying your chances of being bitten is delayed, and also and you're growing older. So that's why we see that kind of shift. But in high transmission intensity levels, your chances of being bitten are quite high. And so you find that very young children have severe disease because the probability of being bitten is much higher compared to lower transmission sites. Hope I answered all your questions.
Well, thank you.
Thanks, Alice. So we can move on to Andrew.
Okay, so Victor, my name is Abel Walekwa.
Okay.
I am seated near Dr. Andrew here.
Okay, no problem.
Okay, I should also acknowledge that I'm among the products of SEMA fellowship sessions, but also my being here partly is because of SEMA fellowships. So Alice, thank you so much for a very nice presentation. I come from Uganda, and therefore I have a very good understanding of your findings, of the results that you present. And I really thank you so much. And also what you clearly bring out on the admission rates and the severe malaria, more so among infants. It is a true picture, and it is the real situation on the ground. I'm just praying that your collaboration with the Swiss IPH works out very soon, because the burden of malaria, more so among children, among the 5 years in Uganda, is a big issue. I have a lot of interest in malaria. We have a project we are trying to come up with an intervention of a mosquito repellent. And so we'll be doing in Tororo and the Apache. Actually, part of, for us to come up with those sites, your work partly informed it, and that's why I should thank you so much for that. Now, I have a number of questions I want to raise to you. One is, I'm just curious why you included Kavale in your study, I'm aware that Kabale is not in the malaria belt in Uganda, for example, and also it's a cold spot. It is a cold spot where the incidence of malaria is really low, but I'm just curious why you got interested to go and study that. The second question is, did you try to use DHS I2 data, for example, for Ugandan case? And then the other question I was eager to see further analysis, if at all you did it, between the school-based surveillance that you did and the community-based surveillance that you did. And then the other question I also maybe could come under limitation is, if I get you very well, this was self-reported data. I don't know whether that is true, but I just wanted you to comment on that among the study limitations. The other issue I just wanted to bring out, I was part of the Ministry of Health team that went to do capacity building and mentorship of health workers in Tororo and 4 of districts in eastern Uganda. I want to shock you that the knowledge levels among health workers themselves to diagnose cerebral malaria, but also to document and to communicate to patients is a big issue. And so we are putting up a paper on that. Maybe as you plan future interventions, you could also intervene on that as well. But was this self-reported data? And if so, the health workers' knowledge on categorization of these malaria stages is another issue for you to point out for future presentations, either as a limitation or something in that line. The last question, I'm just curious to see, how was this malaria diagnosed? Was it by RDT or it was by BS? Over.
All right. Very many questions. So the reason why we included Kabale was we wanted to include the whole range of transmission intensity. So it's not just Kabale, we also have Kilifi North, which is of very low transmission. And we also wanted to see the effect of very low transmission on the incidence of severe disease. So it's just to cover the whole range. So we did not choose the HIS2 data because of its validity and incompleteness. And so we reserved or left we purposely, like I said, purposely selected these 13 hospitals. And this is because, like I said, they have continuous pediatric surveillance. And some of these have been funded in Uganda, for example, I know Tororo has been funded to do monitoring of acute febrile illnesses. And so the data is a bit more robust, and we are confident, and people are trained how to identify some of these signs and symptoms. So it's not just health facilities, these are major hospitals that have been funded. So the Western Kenya, for example, there is a clinical information network that is also funded by the Wellcome Trust in order then to collect this kind of information in a more accurate and in a systematic manner. And all these data are electronically recorded, and they obviously have also backup copies of records that we can go back to if we have any questions on how things were done. But these studies that I have included for this work were, like I said, purposely selected, and they are funded to do some of this work. And so the data that we were able to obtain from these sites the completeness and the validity of it, we were a bit more comfortable than using the HIS2 data, for example. And how we confirmed malaria was by microscopy. So all these sites have also been facilitated to conduct microscopy, or what you call BS, blood slides. Is there anything else? Can't remember what you asked about the community versus school-based service. I'm sorry. But yeah.
Alice, I was just curious if you did a further analysis to see how the transmission, but also the severity was playing out between community level and the school-based surveillance. I was just curious if you did that further analysis.
So I guess the only differences between community-based and school-based surveys is that the people that, so for the community-based, you would include all ages, but the school-based surveys, you'd include children aged between 5 and 17 years. And what that means is that there would be differences in the transmission intensity measure that you get. And so I demonstrated how we try to standardize those two measurements in the 2 to 10 age range. And the reason why we standardized in the 2 to 10 age range is because across all transmission settings, there is always PR tends or parasite prevalence tends to peak in the 2 to 10, and then it rises, peaks in the 2 to 10, and then declines across all transmission levels. So how to then compare the school-based and the community-based was to try and standardize those two measurements to then come up with a measurement that you can compare across sites and across time periods. So that's how it's done. That's how we do it, and that's how most of the people would do it. If you understand what I mean.
Thanks, Alice, and thanks, Abel, for that question. I think I'd encourage you the two of you probably get in touch or stay in touch to continue this conversation. We've just gotten to the hour mark, and kindly give us 10 minutes to try and wrap up. So I'll go to the last person with their hand up, Lenson, to ask their question.
Yeah, thank you so much, and thank you, Aris. My name is Lenson Karaoke. I work with the Division of National Malaria Program in Kenya. I'm also a PhD student in the Department of Microbiology, University of Nairobi. So mine is not major questions, but there is a point Aris mentioned that Nyakach was doing IRS at some point, then they lifted IRS and the cases of malaria went up. I don't know whether it's now or it's sometimes back, because as far as IRS is concerned, we are only doing it in Migori and Homa Bay. And in connection to this, if this was informed probably by modeling that you are doing, or probably you may wish to do, then I think it will be important we get some of this information, because right now we are struggling on how we'll exit some sites in Homa Bay in fear that the cases of malaria might increase. Then probably you can escalate your presentation or your findings further to NMCPs from the implementers' perspective, so that we can use some of this information for decision making. Thank you.
Thank you so much. Sorry, just to confirm, it was a patch in Uganda, not Nyakach in Kenya. But I guess the same scenario would occur if IRS was withdrawn in some of these sites. But good suggestion. We will, obviously, Bob Snow has a lot of collaborative work with NMCP, and so we will definitely get in touch. Thanks.
Thanks, Alice. So to finalize, we'll just move to the final comments on the chat. So I'll start with John Gashoki. So his question is, did you collect data on other health conditions that may accelerate the clinical burden of malaria, warranting higher transmission rates, higher admission rates, sorry?
Yeah, so I think I mentioned this when I was talking about how we defined malaria. So we excluded major underlying conditions, for example, sickle cell and HIV, and this we obtained from the discharge diagnosis. And the reason for doing this was because the assumption was that these conditions were probably the reasons why these kids were coming to hospitals. And so in a way, we were controlling for comorbidity in some sense. It's not the best way. We are also evaluating how best to accommodate comorbidities in the modeling of the effect of transmission intensity on severe disease, while also accounting for the presence of other diseases that might present, because a child might come with more than one condition to hospital. But that's how we did it in this analysis. But we accept that as a caveat or a limitation, and we are trying to address that in further analysis with Swiss TPH.
Oh, thanks, Alice. So Thumbi also wants to know how your findings tie to the malaria elimination goals, and how your findings can help tailor interventions within a country, for example.
So I guess it's more of control more than elimination, because I think we are far away from getting to the point where we can talk about elimination, but obviously that's the ultimate target or goal. And so for example, like I said, there are sites where the transmission is quite low and the burden of severe disease is also low. So with for example, the rolling out of RTSS, the priority, we can try and use this data to prioritize areas that from the data that we've got, we can see which areas are of high immediate need because of the rate of severe disease. And so I guess in that way, like we say, the RTSS is targeting severe disease, and so this would obviously help guide that in a way, in a sense. But obviously, this is not something that we are doing at the moment, but we'd hope would inform how then RTSS is rolled out in East Africa, for example, or in Kenya. But also there are plans to try and use geostatistical models to try and use this data and extrapolate in areas where we didn't have data to collect and see what that looks like in terms of severe disease. And maybe that will also help in the targeting of RTSS in the future, or in the days to come.
Thanks, Alice. There's a comment from Tabitha, who's a pioneer of some of this work. So her comment is that cerebral malaria was usually a feature in older children compared to infants. And she wants to know your thoughts on the effect of declining transmission rates on higher rates of cerebral malaria. I hope I got that right, Tabitha.
So my thoughts on the declining transmission on the, sorry.
On higher rates of cerebral malaria.
I guess the hypothesis still holds. Like, I mean, the data that we had on cerebral malaria was not, I could say, wasn't adequate to make a conclusive decision on what, or make a conclusion on what that effect might be like. But the initial hypothesis of cerebral malaria being a disease of the older and more prevalent in low transmission sites still holds in our data. And like I said, the proportion of children that would be seen in low transmission sites would have cerebral malaria compared to the other severe disease phenotypes. But I can't comment so much about it because the data we had wasn't adequate enough to really say that with certainty.
Okay, thank you. So the final comment is from Helen Muringi. She wants to know if there's correlation between wealth quartiles and severity of malaria.
We did not look at social economic status in these analyses. We were just looking at what the effect of transmission intensity might have on the presentation of severe disease. So I guess this is something we could consider in the future to include other indicators or factors. But I'd assume it would definitely have some effects, but we haven't looked at that.
Okay, yeah, okay. Thanks for that, Alice. And thank you everyone for your comments and questions. I think that brings us to an end. Yeah, I think, yeah, it's been a useful interaction, and we encourage Alice, if you have any ideas of other people who could participate in the seminar series, kindly suggest that. And feel free to visit SEMA, and all the best in your future work.
And thanks for inviting me. Thank you so much for making time to join the seminar. Thanks, everyone.
Thanks, Alice.
Thank you, everyone.
I appreciate it.
Yeah.
All right. Cheers. Bye-bye.
Thank you. Bye-bye.
Bye.